drug for T790M positive patients. But now I think in light of the approval of osimertinib, I would say tissue biopsy is important at the time of progression, and that would A, tell you whether the patient has T790, and B, also identify those converters to small cell that would need to be treated with small cell type of chemotherapy. And as Paul just pointed out, in terms of when do you switch from first to a second or a third generation agent, not second but third, you have to keep in mind that as somebody who's clinically benefiting, has minor radiographic progression or solitary progression, may still be salvaged with local therapy and can be continued on frontline agents. So use of local therapy for isolated progression is very much a strategy we would continue to do even in the presence of approved agents for T790M positive disease. The one question that was asked for a long time, which was whether you should continue the TKI if we switch to chemotherapy after progression, was answered by the IMPRESS trial. This has now been published in Lancet Oncology. Here was a group of patients who progressed on gefitinib, or I believe it's gefitinib progressors for EGFR mutation positive disease, randomization to chemo plus gefitinib versus chemotherapy alone. And in this trial, the progression-free survival was very similar. In fact, the overall survival results were in favor of group that got chemo plus placebo, suggesting that continuation of gefitinib after progression was not necessary. And this was in the days when chemotherapy was the preferred second-line therapy in this patient population. One would now argue that the considerations changed slightly because in second line now we have a drug for patients who have T790 positive disease. So these are memorial data from Helena Yu, which showed that the study showed that nearly 60% of the patients in their series had a T790M mutation at the time of progression, and their small cell conversion rate was about 4%. Some of these patients had MET amplification to go with it, and those patients may be a distinct entity that would be treated differently. Here is the schema for the AZ9291 or osimertinib study. This was the phase 1 trial where patients received escalated doses from 20 to 240 milligrams given once a day. And at each dose level, there was cohort expansion. At the end of dose escalation, it was very clear that the 80 milligram dose had the best therapeutic index. When the dose went beyond 80 milligrams, there was additive toxicity. There wasn't any clear suggestion that efficacy was going to be improved. So the 80 milligram dose was chosen for further development of this drug. Here is the response rate in the overall patient population. This is regardless of whether the tumor had T790 or not. And that number was 53%. For patients who had the T790M mutation, the response rate was 64%, and the clinical benefit rate was approximately 95%. Adverse events with osimertinib are summarized here for various dose levels. If you look at the 80 milligrams, which is the dose that's being developed further, and the approved dose now, in fact, grade 3 toxicities are uncommon. ILD-like events are seen in about 2 to 3% of the patients. That's something to keep an eye out for if you do recognize worsening dyspnea or symptoms, pulmonary symptoms that would indicate ILD. You want to recognize early and rule out other causes and treat that appropriately. You don't see hyperglycemia or QT prolongation with osimertinib. This slide shows the differences in response rate between T790 positive and negative patients. There was a small subset of patients who were T790 negative that responded to the drug. That's about 20%. But even there, if you look at patients who just progressed on a TKI before they came in, the response rate was lower. So this was probably more of a reintroduction of a TKI phenomenon. But some patients who are T790 negative may have been negative because of the fact that the sample obtained from that part of the tumor may not have had those cells. But regardless, the approval is now for T790M positive patients. This is the progression-free survival data from the New England Journal publication by Pasi. Again, T790M group did much better compared to negative group. Here I show you data from 2 phase 2 studies that Glenn Goss just reported 2 months ago at the ECC meeting. About 400 patients included in this data set, and median duration of response was not reached. The maturity was about 23%, and you can see here that majority of the responders were still ongoing with treatment. In terms of progression-free survival, the median appears to be about 10 months. Again, the data are not fully mature, but a fairly large data set, and these were all by blinded independent central radiographic review. The response rate about 60 to 65%, median PFS about 10 months with osimertinib in the second-line setting. And this is the FLORA study that takes this drug to the frontline setting that compares osimertinib to gefitinib or erlotinib that Mary just showed us. And this trial is ongoing for accrual and nearly 2/3 of its way done. Ruxolitinib, it's another irreversible, highly potent inhibitor. This is also a drug that inhibits the native 19 and 21 exon mutations, plus the T790M mutation. These are preclinical data that show that this is active when afatinib was not active in the transgenic 858R and the T790M positive models. During the development of this drug, what delayed the development was the switch from the free base to the hydrogen bromide salt formulation. And right now, the phase 1 trials have showed that the drug can be escalated up to doses of 100, though the 500 appears to be the dose that's being studied further. Here you see the waterfall plot in 250 patients, T790M positive. This was the most recent reported ASCO at 60%, but we now know from a press release in the lay public media that the response rate may be about 30% or 28% with ruxolitinib. Confirmed responses, that is. These are PFS data reported by Licia at ASCO, approximately 8 months for patients who did not have brain disease. The PFS was slightly longer at 10.3 months. And the main toxicity this was not me. Right. The main toxicity that one sees with this drug is hyperglycemia. Majority of the cases are grade 1 or 2, but about 20% of the patients develop grade 3 hyperglycemia. When they looked at the 500 milligram dose that was being developed as the planned dose upon approval, the hyperglycemia incidence seemed to be lower compared to the higher doses. This is related to a metabolite that inhibits IGF-1R. So many of these patients received metformin in a prophylactic manner or after they developed hyperglycemia. No ILD was seen in this particular drug with this particular agent. QTc prolongation, however, is seen in about 2 to 3% of the patients. There is an extensive program that is looking at the role of ruxolitinib in a variety of settings, TIGER-X, and then TIGER 1 to 5, first line, second line, randomized, non-randomized, what have you. So really, this drug is also in front of the FDA for approval. They have a deadline of somewhere around March to make a decision, but with the recent announcement, how this is going to change further development of ruxolitinib remains to be seen. Now, lastly, I want to finish up talking about acquired resistance to AZD9291. We are beginning to understand what causes resistance. This is Jeff Oxnard's presentation from World Conference. He looked at plasma samples from 67 patients that participated in the AURA trial with osimertinib that had developed resistance. And when you look at plasma cell-free DNA, 20% of the patients developed the C797 mutation. Now, the 797 site is exactly where osimertinib binds to and forms the covalent bond. So when you develop a secondary mutation there, the drug is rendered ineffective. And interestingly, 50% of the patients who progress on osimertinib no longer have T790M mutation at the time of progression. We'll learn more about this. So they end up escaping through different mechanisms. They no longer have the T790M mutation. And the other mechanisms that have been seen include MET amplification, HER2 amplification, and BRAF mutations. So this is a nice paper that was published by the Jeff Engelman group, which looked at mechanisms of resistance and how you may be able to treat in patients. So I'll walk you through this. You have a patient who has EGFR exon 19 mutation. You have the native mutation here. These patients are treated with the first generation TKI. And after a while, they develop in half the patients the T790M mutation. And then you come in with the third generation TKI. And when they develop resistance to the third generation, especially if you look at the C797S, it is important to know whether it is in the same allele or in a different allele. So if you see the C79S in the same allele as the T790M mutation, then at least in preclinical models, they don't respond to continued EGFR TKI inhibition. But if you see the C797 in a different allele than the T790M, in preclinical settings, they respond to the combination of first and third generation TKIs. So you may be able to come in with gefitinib or erlotinib for these patients to rescue them from resistance to osimertinib. Now, if you now go to the first line scenario, if you give these patients a third generation TKI in the first line setting, they don't develop T790, and they may end up developing C797 mutation. And in that case, you may be able to treat them with the first generation drug at that point in order to reverse the resistance. So the escape mechanism may tell you how to treat these patients. Another interesting preclinical observation is some of these patients who develop the C797 may be sensitive to cetuximab, and therefore there may be a role for cetuximab, which inhibits EGFR at a different level. There are also trials looking at combination strategies with osimertinib. This is the TATON trial. Jeff presented the preliminary data at ASCO. This looks at combinations of AZD with immune checkpoint inhibitor, a MET inhibitor, and a MEK inhibitor. And this is an example of a case that Jeff treated that had MET amplification, a T790 negative tumor that responded very nicely to the combination of AZD plus savolitinib, which is a MET inhibitor. This is a patient we treated at Emory, a 60-year-old lady who had progressed on erlotinib and afatinib. Repeat biopsy didn't show any other specific mechanism of resistance, was treated in this combination trial of AZD plus MEDI, and started in February 17, had near dramatic improvement, and as of this week continues on therapy without any major clinical side effects or progression. So it'll be interesting to see what was responsible for patients such as this one responding. Finally, cetuximab afatinib combination has been shown. This has been around for a while in treating patients with EGFR mutation positive disease. William Pau's data showing that the combination had improved efficacy in a resistant model. Clinical data that was reported last year showing waterfall plot with response rates of about 30%. Activity was seen in both T790 positive and negative patients. So for T790 negative patients, I think this is still something that's interesting enough to study, or for T790 positive patients after they progress on osimertinib, this could be studied. This is the SWOG study that is looking at the combination of afatinib and cetuximab in the frontline setting for newly diagnosed patients, randomizing patients to afatinib versus afatinib cetuximab. It'll be great to have another study in the third line setting or second line setting for T790 for this group of patients as well. So I'll stop there and thank you for your attention. I'd be happy to take a question or two. Jeff.
Plasma assay for T790M. Where are we with that? And you know,
So,
for example, can we do it now and
yes,
look at reimbursed?
I mean, there are commercial companies that offer T790M, and at least with the ruxolitinib data that Alicia showed, whether you have T790 positive in the tissue or in the plasma, the response rates with the ruxolitinib were the same. So I think we will soon be using it. The companion diagnostic approved for osimertinib on the FDA label is tissue-based testing. And there are studies ongoing to get that label adjusted based on peripheral plasma testing. But if your payer would pay, if you have the T790 positive, it's certainly reasonable to go with it. What I would say is, if you have plasma T790 positivity, it helps you. If the test comes back negative, it does not imply that the patient does not have it. So a positive is helpful, negative is not.
You mentioned that the resistance mechanism to osimertinib in the first line are not or not C797S. Can you say anything more about what has been seen, or is there anything you can?
So in the frontline study that we reported at ASCO, there were 60 patients, and the number of patients who have progressed is relatively small. And as the study matures, we'll have a better understanding. But in a preliminary manner, when we looked at the plasma of these patients, we didn't see T790. John?
Actually, a little question follow-up on Dr. Crawford's is that there's also data that patients that biopsies are negative for T790M may actually have it in the circulating tumor cells. And like you said, it doesn't make a difference where you find it. So the question is, if you have a patient who you don't find the mutation, do you ever look at circulating tumor cells and to see if you have the T790M mutation?
I think that's certainly reasonable. At this point, I'm hesitant to say don't do biopsy, just go with plasma, because you'll miss the small cell conversions. Even though it's a minority of patients, you don't want to miss them. If your tissue testing is negative, I would say don't wait for plasma tests to come back. Perhaps start them on chemo or something else, but certainly you can send the plasma out and see what comes back. Right. Thank you. So we'll move to the next talk, Bepi.